You are asked to review a patient who is in ICU. He had a radial arterial line inserted and has been there for about 1 week. Since 24 hours, they have noted that the thumb and the index finger looking dusky. The arterial line has been removed yesterday. On examination of the left hand, demonstrate dry gagging of the thumb that is sharply demarcated at the level of mid-portion of the proximal phalanx. The left index finger also demonstrate dry gangrene, and there is a gradual zone of transition. No other software compromise is noted about the hand. The ulnar arterial pulsation is easily palpable at the wrist joint, whereas radial pulsation is undetectable either by palpation or Doppler examination. A small puncture wound is present 3 centimeter chymotic area at the level of radial pulse. Nursing staff confirms that this is the site of arterial line placement. The arterial line was an 18-gauge angiocatheter which was removed as it was not functioning. What is it? The clear history depicts a complete occlusion of radial artery post-cannulation. There can be differentials like radial artery thrombosis due to cannulation injury, embolic event of the digital vessel, small vessel occlusion due to diabetes mellitus or vasculitis, and digital ischemia because of pharmacologic blood pressure products like neosynphrine or other vasoconstricted or localized severe infection. For the diagnosis studies, an upper extremity angiography was performed, which showed complete occlusion of the radial artery just proximal to the wrist joint. The ulnar artery was providing little flow to the radial side of the hand. Some collaterals were present which were coming from the ulnar arch, although no large vessels could be seen extending distal portion of the thumb or index finger. An arterial cannulation is a common procedure, but the complications can be devastating as well. Understanding the arterial anatomy of the hand is a key in accounting for cannulation injuries. The two main arches that support the vascularity of the digit, the superficial palmar arch, which is the extension of ulnar artery, and the deep arch, which is generally arising from radial artery. The superficial arch, or ulnar arch, which is slightly more distal and palmar than the deep arch, that is the radial arch. The ulnar arch is the primary blood supply to the ulnar 3 digits through its connection with the volar digital arteries. The deep arch comes off the radial artery, where this vessel drops down through the anatomical snuff box and branches into the principal pollicis artery of the thumb. This large vessel to the index finger terminates at the deep palmar arch. In the usual circumstances, both arches connect to each other. The ulnar arch often terminates as a small diameter vessel that connects to the superficial arch branch of the radial artery. And the deep radial arch usually terminates in the ulnar palm by connecting to the ulnar arch via collateral vessels. There can be, however, greater variability in the specific vascular connections in a hand. There can be variability like a median artery, which is present at fetal development and can persist as a major vessel and contribute additional blood flow apart from these two arches. Most importantly, the two main arches may exist as an incomplete pattern in which there are minimal connections between the radial or ulnar derived vascular tree in the palm. It is thought that an incomplete arch exists in 20% of the hands. And in this scenario, the thumb and index finger derived more, if not all, of the blood supply from the radial artery. Identification of individual at risk of radial artery cannulation injury therefore relies on noting the presence of incomplete arch vascular anatomy. Sometimes a history of cold intolerance in the hand provides a clue, although more commonly physical examination of vascular imaging is necessary. The modified Allen test involved manually occluding both vessels in one hand of the patient, making a tight fist several times to pump blood out of the hand. When the patient digits gently extended, the radial artery is released and the time required for the palm to regain its normal color is noted. The test is then repeated, noting the refilling time for the other artery release. The overfilling time is between 2 to 3 seconds. A positive Allen test or a failure of palmar capillary fill is less than 4 or 5 seconds is suggestive of incomplete arch vasculature. The vascular examination of the wrist and the hand can be further worked up by a variety of more sophisticated methods, including Doppler ultrasound, pneumoplethysmography, and angiography. It should be noted, though, that the timed Allen is a remarkably simple and accurate screening test that can identify patients with incomplete palmar arches. Apart from vascular anatomy, there are some other factors which can cause ischemia when you are doing cannulation. A smaller cannula, size 20 gauge, seems to be less likely to produce thrombosis than a larger one. Teflon catheters that are irrigated regularly seems to produce less thrombosis, producing irritation than heparin-coated polyethylene catheters. Duration of catheter presence is also an issue. The longer the catheter stays, the more likely it could occlude. One study has shown that catheter present for more than 40 hours, thrombosis is present in 93% of the patient, compared with 25% when the catheter is removed within 20 hours. In most cases, even if the thrombosis of the radial artery occurs, the presence of complete vascular arches prevents critical ischemia from occurring in a particular part of the hand. Furthermore, in many cases, the thrombus is recanalized over time and does not require any intervention, and there are no clinical symptoms as well. Medical conditions may be present that may further lower the threshold for such critical ischemia. Ischemia examples would include hypertension, vasoconstrictive drugs, diabetes, peripheral vascular disease, coagulopathy, and Raynaud's phenomena. In clinical setup described in this one, note that the patient was initially hypotensive and received vasoconstrictive drugs, while a catheter of 18 gauge was placed instead of 20 gauge, and the catheter was there for 3 days. All these issues impact producing gangrene if vascular arch are incomplete. Anyhow, in our patient, a protective splint was applied to the hand to prevent trauma to the compromised digits. 1 week later, when the patient had medically stabilized the thumb and index finger, amputation was performed. No further progression of necrosis had occurred later on in the assessment. The index finger was treated with an amputation through the distal portion of the middle phalanx. Digital neurotomies were performed at the amputation site. No infection was noted. Mid-lateral incisions were used and direct closure with fish mouth type of wound closure was possible. Post-operatively, a radial cutter splint was applied for 1 week time. Dressings were changed to demonstrate good healing of the wound, and occupational therapy was started at the first dressing change to aid in stump desensitization and proximal joint movements. And alternate to the above, a compromised hand with the radial artery thrombosis usually attracts attention after irreversible ischemic necrosis has occurred. If hand ischemia is identified very early, alternative therapies may be possible. Such intervention includes intravenous heparin or low molecular weight dextran, intermittent sympathetic block, intra-arterial administration of reserpine or piperine. Methods to improve cardiac output may also help. Surgical intervention via thrombectomy and repair of the injured vessel segment may be necessary to avoid gangrene of the radial digits.